Welcome, everyone. Thank you so much for being here today, joining us at the SRSF, the Sleep Research Society Foundation's Industry Scientific Seminar. My name is Phil Chang. I am pleased to be here as the president of the SRS Foundation. And we are pleased to host this series of educational webinars where attendees will learn the science behind a sleep treatment directly from industry scientists with a question and answer opportunity. So let us explore how our shared mission of growing knowledge can help further the field. Please note that the SRS and the SRS Foundation do not endorse any products discussed on today's webinar. Speaking of, today we will be learning about a talk titled Rethinking Sleep Apnea in Women, New Data, New Insights, New Directions. And this will be presented by the Sleep Institute Clinical Insights by Resmed. So without further ado, let me introduce and turn over the webinar to Dr. Alison.
Hey, good afternoon. It's really my pleasure to be here. My name is Alison Wimms. I'm a director at medical affairs at the Resmed company, and I'd like to talk to you today about rethinking sleep apnea in women, new data, new insights, and new directions. So to give a brief overview of the agenda today, first I want to paint the picture about what obstructive sleep apnea looks like in women. So talking about the prevalence and symptoms, different PSG features, the difference that we see anatomically, hormones, ventilation and cardiovascular, and then how these patients look when they present clinically in our sleep clinics and primary care clinics. Then I want to move on to some of the key issues in our field that are particularly damaging for women, such as scoring criteria, looking after our patients with mild OSA, making sure we have fair representation in clinical studies, some of the problems that women with sleep apnea have in the different pathways, and the problems with focusing a lot of our screening on sleepiness. Finally, new data and insights, some new papers that have been published in the last 6 months, and some of the projects that we're working on here at Resmed. So let's dive right in. So if we look at the global prevalence of sleep apnea, it's probably about 22% of people, and from that group, about 9% having moderate to severe sleep apnea across the globe. What we see quite consistently is that women with sleep apnea present with very different symptoms than men do. So these classical OSA symptoms that people have learnt about, particularly GPs, and that are associated with sleep apnea, like snoring, witnessed apneas, and excessive daytime sleepiness, are not always what women turn up to the sleep clinic talking about. So when women go to the GP or end up at the sleep clinic, quite often they're likely to talk more about fatigue, and fatigue being a kind of quite general term describing lack of energy, lack of motivation, lack of ability to sort of get things done, to keep on top of things, and just not having that energy. They often talk a lot about insomnia and waking up during the night. So this idea of I can't fall asleep and I can't stay asleep. And it gets quite difficult, and you'll see as we go through this talk some of the recurring themes. And one of them is this misdiagnosis of women, because these symptoms can be very general and they can sound a lot like anxiety, depression, things like that, when women talk about, I just don't have energy during the day, and I don't have motivation, and also all night I'm waking up, I can't stay asleep, I can't get a good night's sleep, I never feel refreshed. It doesn't really sound like sleep apnea, or what we've been trained to think of as sleep apnea, in terms of, well, I can't have sleep apnea because I'm awake all night. People with sleep apnea, they fall asleep everywhere. They fall asleep as soon as they kind of go to bed. They're always sleepy. So it's not always the case, right? Women will often talk about fatigue and being awake during the night. And so it can sound a lot more like sort of anxiety, depression, different mood disorders when they start speaking to the doctor. Difficulty concentrating, difficulty completing tasks, cognitive function, headaches, especially morning headaches, and general muscle pain, and restless legs often comes along with OSA in women as well. And what we know from a lot of the literature, even that was done by Terry Young way back in '96, that has held true through the years, is women generally don't like to complain about snoring, and often they visit the doctor by themselves as well. So what that means is the bed partner isn't there to give this extra piece of missing information. So when men go to the doctor, often they go with their wives or their bed partner, and the partner is saying, well, he's not breathing during the night and he's keeping everyone awake with his snoring. When a woman goes to the doctor and she's by herself, that piece of the puzzle is often missing. We also see in different cultures and whatnot that women tend to go to bed last. They're expected to be up first to get breakfast and everything ready for the day. They're expected to be looking after the children at night. So often there's not as much focus or understanding of what happens during the night for some of these women. And also there's a lot higher acceptance of tiredness being a normal thing in women than there are in men. That's another one that's been consistently found in different regions and different big surveys like the AASM 2023 and 2024 survey, and also the Resmed sleep survey. We just find that women will accept a much higher level of tiredness before they'll actually go to the doctor and do something about it. As well as the symptoms, we also see a lot of differences in PSG studies. So generally, and I should put a caveat in that when we're talking about these differences between males and females, of course, we're talking about as a group and the group averages. There are crossovers. There are absolutely men that have OSA that look more like these women and have symptoms that are a little bit more like the norm of women. And there are women that have very, very severe sleep apnea and present with more of the classical symptoms that we're used to seeing in men. So no hard and fast rules, but when we look at the group averages, what we see is that women with sleep apnea tend to be more mild. They have lower AHIs. The apneas are often short. They're often hypopneas more so than full apneas. And they tend to be broken by arousal from sleep rather than severe oxygen desaturations. We'll see a lot more flow limitation in women's sleep studies. They have more REM related events. In fact, it's not at all uncommon for women to have REM only OSA, but they don't tend to have supine only OSA. That's positional OSA is less of a thing in women. And you can see from this PSG image here, from the nasal flow, a lot of notched breathing, a lot of snoring going along, and it's not unusual to see this type of breathing in women. It can last for ages. We can see quite severe flow limitation for a long period of a sleep study before they'll have an arousal. So we'll talk about it a little bit further in the presentation, but it does make it difficult to sometimes score hypopneas and definitely apneas if they don't exactly fit the criteria. We know as well, if we take OSA out of the equation, that women compared to men, there are differences in sleep. Sleep studies will show us that women tend to have a longer sleep latency, so they take longer to fall asleep, less total sleep time, less sleep efficiency while they're asleep. I'll add to that though, these are from studies that have been done in PSG labs. Now that we're getting more and more data from wearables, I think we're seeing a little bit more of I think we're seeing a different picture of what sleep looks like between men and women, and we're seeing more data suggesting that women actually sleep longer, maybe even up to an hour longer every night, or at least need a little bit more sleep every night than men. And potentially, real world conditions versus sleep lab conditions. But I'll talk about that a little bit more in the future as well. All right, so why do we see these differences between men and women? Well, if we go back to the pathophysiology of OSA, it's a combination of different things, right? There's anatomical factors, there's variable contributions from the three functional factors like ventilation instability, high loop gain, neuromuscular issues, and arousal threshold. And we see differences in each of these ones between males and females. So in the anatomical difference, particularly in the upper airway, there's a lot more fatty tissue in males than females. And I'll talk about these more as we go through the slides. There's absolutely hormonal influence. So female sex hormones are very protective against upper airway collapse. And control of ventilation, women tend to be a lot more responsive to changes in blood gases. And we also see some differences in how the cardiovascular system responds to OSA in women than men, which I'll talk through as we go. So starting with the anatomical differences, particularly around the upper airway, we see quite consistently in MRI imaging and other studies that everything in the upper airway, so the length of the upper airway, the tongue, the soft palate, the total amount of soft tissue in the throat, they're all smaller in women than men. So men tend to hold a lot more of that fatty tissue in the upper airway. And when you think about advice that's often given to people with mild sleep apnea, which is, look, maybe lose 5 kilos, we'll see if that helps first. In men, that can make a big amount of difference because they can lose that fatty tissue from the upper airway. Whereas in women who tend to store their fatty tissue more in the stomach and the thighs and the bottom, they're much less likely to see differences in sleep apnea from losing a few kilos. Might feel happy and feel good about it, which is great, but yes, it's less likely to impact their sleep apnea. We also see that it's much easier to collapse the upper airway of men. So the pharyngeal walls, and if you think about the pCrit, it's much easier to pull them together in men. It's a combination of fatty tissue and the shape of the upper airway. It comes together much more easily. And also in women, we see there's a lot more upper airway muscle activity and much better responsiveness or push against any collapse. The joke, of course, that I often hear is that women have better upper airway muscle activity because we speak a lot more, and therefore our throats are trained to collapse less. The amount of things going on in the upper airway just make it completely collapse the upper airway. The next reason tends to be this loop gain, and tend to see a lot more higher loop in men than in women. What tends to happen is that starting with an apnea, the magnitude and the response to any sort of ventilatory disturbance, such as apnea, in men tends to be much greater. So we'll see men will have this event, usually an apnea. Their CO2, of course, rises, their O2 drops. They'll let that go for a little while, and then when they wake up, they will work very hard to blow off that CO2. They'll hyperventilate, they'll get, and then they'll be too low on CO2. So they'll return to sleep, and now they've got to build that CO2 up again. Often kind of leads to centrals and this respiratory instability where they get out of sync with their breathing and their airway activity, and you go around in this circle of breathing disturbances. It's why we often see men having a lot of apneas and sometimes centrals and obstructive apneas when they first fall asleep, while they go through this kind of phase of instability before they settle, whereas women don't tend to do that so much. What women do tend to have as a group is this lower arousal threshold. So meaning that where women are waking from sleep, sometimes fully waking up, sometimes microarousal that they're not aware of, but particularly in response to any change in ventilation. So anytime that CO2 starts to rise a little bit in women, they will wake up very, very quickly and correct that, correct those blood gases very quickly. So I've sometimes thought of it as this idea that men would rather sleep and they don't mind what happens with their breathing so much. Women would rather breathe than sleep, and they'll stop sleeping very quickly to get their breathing settled and under control. And this may also go some way to explain why we see this these women with sleep apnea talking a lot about insomnia type symptoms and being awake, is that they're getting woken up a lot more from hypopneas and apneas, and they're potentially realizing that they're awake, being awake, thinking, well, I'm awake again, without realizing that the cause may be a breathing disturbance. So in terms of the cardiovascular risk or outcomes, when we see this, untreated OSA has very strong associations with poor cardiovascular outcomes, particularly stroke and chronic heart disease. And in fact, in OSA patients, just female sex, just being a female, is an independent, significant predictor of cardiovascular diseases, especially younger and our non-obese patients. So why? It's not exactly clear, of course. It's complicated. We have the normal mechanisms: hypoxia, oxidative stress, the sympathetic overactivation and sympathetic, so systemic inflammation that occurs with just sleep apnea in general. But women seem to have this more damaging response to particularly hypoxia in terms of their endothelial function and calcification in the coronary arteries. So it looks like this, and I'll talk about it a little bit more as we go through some of these slides, but yeah, the same impact or the same apneas seem to have a much greater damaging impact in the cardiovascular system of women, more so than men. And then also there's absolutely some interplay between depression and overall health status. And we'll see a little bit further that women with OSA at the time of diagnosis tend to have a lot more other conditions. And there's obviously a lot of interplay going on between them, leading to their overall health status as well. And then the female sex hormones, of course, being the big one as well. So we know that they are very strong respiratory stimulants. They absolutely increase our chemoreceptor responsiveness. They help contract the upper airway muscles, which is another reason that we're protecting against collapse and stimulating ventilation. So if you think again about women responding very quickly to these changing blood gases and having an upper airway that's much harder to collapse, we do see that this is no doubt a huge impact from the female sex hormones. So of course, post-menopause, we see this real jump in the prevalence of sleep apnea in females. Also, though, we mustn't forget that just, of course, getting older, we lose muscle tone, fat distribution changes as well, so putting us at risk as well. So talking a little bit about or thinking about what our women with sleep apnea look like when they're getting diagnosed. So this is some data from Turkey and Greece, and also from our Resmed's big data set that we have, 800,000 US female patients. At the time of diagnosis, women have significantly more comorbidities than men. It's about 3.4 compared to 2.7. And you can see in this slide, comparing these three data sets and looking at the prevalence of these comorbidities in females versus males, just how strong that, or just how, just what this burden of comorbidities is. So insomnia, anxiety, and depression, of course, much more prevalent in our females. But then hypothyroidism, asthma, diabetes in these populations, arrhythmias, cardiovascular diseases, hypertension, for the most part. The percentage of our patients turning up with these conditions at the time of diagnosis, much higher in women. So they're turning, at the time of diagnosis, they're a much sicker population. They are getting diagnosed slightly later than males, and maybe that has something to do with it as well. But yeah, absolutely, they need a lot of extra care when we're trying to navigate helping them. And just also on the topic of looking at what our female patients with OSA look like, the ASADA team have done a great job trying to cluster these patients and looking at variables like age, BMI, sleepiness, comorbidities, and AHI, try to pull out these distinct clusters of female patients in terms of what their symptoms are, what their comorbidities are, and how successful they're likely to be on CPAP. Quite interesting, and I think we'll see a lot more. This type of data is really going to help us understand who our patients are, where they fit, and how we can best treat and look after them. So moving on to the next section, which is the key issues in our fields. I'm going to start with this. I know this is an old one. I'm sure everybody is very familiar with it by this stage, but it's still a huge problem in our field. Excuse me, and one that really needs more attention than I think it's getting. So, of course, back to how should we score hypopneas? Back in 2007, the AASM criteria was that a hypopnea should be 10 seconds, at least 3% decrease in flow, and at least 4% oxygen desaturation. Then in 2012, they revised this criteria. It still has to be 10 seconds. It still has to be 30% flow decrease. But now a hypopnea needs to have, or can have, I should say, 3% oxygen desaturation or an arousal from sleep. This arousal from sleep is a really big one, and I think a key one in terms of female patients who turn up with this sort of type of breathing where they have a lot of flow limitations and what previously you might think of as RERAs, a lot of those now falling into hypopnea categories, because this arousal from sleep really tides them over. And of course, from 4% to 3% desaturation, we also get a much bigger population. So why was the change in definition introduced? Well, back in 2007, all of the studies and the evidence was very much focused on hypoxic burden. Oxygen desaturation at 4% was the strongest correlator to cardiovascular morbidity and mortality. So it was very clear that these were the patients that we needed to focus on, get screened and get treated. In between then 2007 and 2012, more and more studies coming to light and more data about just how damaging constant arousals from sleep are. So there's hypopneas with arousal or not too much oxygen desaturation absolutely are associated with significant daytime impairment, daily functioning, difficulty concentrating, memory, tiredness, fatigue, a whole host of daytime symptoms, as well as parasympathetic activations, cardiovascular activations during the night. There's evidence of insulin sensitivity and glucose effectiveness changing when you have constant arousals. It's yes, it's definitely a huge problem for people that suffer from it. So the scoring criteria was changed, and a lot of you hear people talk about it at the moment of like, well, if people's quality of life is so poor that they just can't function day to day, they may be less concerned about long-term cardiovascular issues and more concerned about, you know, living a better quality of life each day. So fantastic, but of course the difficulty that we're still having in the US is that our payers haven't agreed to moving on to the 2012 scoring criteria. They're still using 2007. They're still citing that there's a lack of evidence about if you score people with this newer, I say newer, it's not new now, but still newer in terms of what the payers are using. If you score people in terms of these 2012 scoring rules, do they improve? Do they get better? There's not enough evidence to show that. And it does increase the patient population probably by about 40%. So of course, that's a significant amount of patients that need to be covered. And I know there's a task force. I think Rich Berry is still heading that task force of trying to update all of the payers, especially CMS, Medicare, Medicaid, to use the latest scoring criteria. This was a nice commentary in JCMS quite recently called "Enough is Enough." strict hypopnea criteria exacerbate sleep-related health disparities in females. And there are plenty of studies, including some Resmed data here, showing that when you change your scoring criteria, it's females who are the ones who most likely get moved into a lower severity and often get moved right out of having sleep apnea altogether. Because they're having these hypopneas with arousal, because they don't have such severe oxygen desaturation, if you're still using, if we're still focused on this older scoring criteria requiring us to have 4% desaturation, then we're not including a lot of these women for diagnosis with OSA and treatment, of course. So this was a clinical trial that we did that Resmed sponsored in the UK a few years ago. So this was called the MERGE clinical study. We were focused on understanding the question, if you score people using the AASM 2012 scoring rules, and they have mild sleep apnea, and then if you treat them with CPAP for 3 months, will they improve? Will their quality of life improve? So it was over 300 patients randomized to either CPAP for 3 months or standard care for 3 months, and our primary endpoint was SF36 vitality scale, and secondary endpoints are a range of questionnaires. And you can see on this table here on the slide that what we found was significant improvements across the board in these patients. So treating mild patients with CPAP and mild, when you scored them with 2012 scoring, led to significant improvements across the board in the SF36 scores, in the FOSC, in the EQ5D, in sleepiness, in fatigue severity, in anxiety, depression, and in insomnia severity index as well. But what's more important with this data set is when you separate out the patients who have mild OSA as per scoring 2012 scoring, so this 3% with arousal, the 3A scoring, versus those who have mild OSA scored with 2007, the 4% scoring. What you find is that there's about a third of the patient in this group, about a third of our mild patient groups wound up in this what we deemed very mild category. So very mild means that they were positive for OSA, so they had an AHI over 5 or above if you scored them with 2012, but they did not have sleep apnea if you scored them with the 2007 older scoring criteria. So 95 patients falling into this very mild category. And what we found was that, first of all, there's more women in this group, as we would have expected. But secondly, from the subjective data, the people falling into this very mild group were the most symptomatic. So they had more sleepiness, more insomnia, more quality of life issues. So what I'm saying is our whole mild sleep apnea group were symptomatic, but the most symptomatic out of this group were the very mild ones, the ones who might turn up to a sleep clinic and get turned away because they don't have sleep apnea, because the older scoring criteria was used. If the newer scoring criteria would have been used, they would have had sleep apnea, and they're extremely symptomatic. And it's a real problem that this is still the situation that we have with clinics using older scoring criteria, that people are still turning up to the sleep clinic with clear sleep disorder breathing, clear respiratory issues during the night, and being told that they don't qualify for treatment because we're stuck on an older scoring criteria. We separated out the baseline quality of life scores in terms of gender. So what we're looking at here is females in blue, males in the gray, and on the left panel, females. On the left panel, everything with a lower score meant that you were better. So what you can see is that, and these results were all significant, women rated themselves significantly worse in every quality of life measure that we had. They rated themselves more sleepy, more fatigue, more anxiety, depression, and more insomnia than the males. On the panel on the right, you just flip it around, and now a higher score means that you're doing better. But again, the women rate themselves worse in every single quality of life measure that we had in the FOSC and the EQ5D and the SF36 scales. So very, very compelling data. I think that consistently we see women more symptomatic, higher comorbidity burden, and then unfortunately more likely to be missed and misdiagnosed when they turn up at the doctors because they look a little different than what we've been educated on. So this is data still from this MERGE trial in mild sleep apnea patients. And you can see that the women started worse in terms of their symptoms at baseline, and then they improved in the CPAP group. They didn't just improve against the control group, they improved again significantly against the males who were put on CPAP. So they start worse, they significantly improve, and they improve against the male group, showing that we can absolutely turn around this quality of life issues with CPAP. They did very well, responded really well to CPAP. And we saw that in the SF36 vitality scale, also in Epworth sleepiness and fatigue. You can see that fatigue didn't quite reach significance, but the trend was still very, very similar there. So how can we support our women through CPAP or treatment in general? What we see, again, fairly consistently, data from Europe and the US presented here, is that in women, older women, worse ODI, snoring, are more likely to do better on CPAP. Those who may struggle are the ones who don't have sleepiness, who need lower CPAP pressures, who have more issues or more comorbidities with insomnia, headaches, type 2 diabetes, and depression, all making it a little harder for them to get on CPAP and get compliant with CPAP. From our big data that we have in the US, we see that generally females can do really well. Again, we see 21% probably the amount not using treatment at all, and then a group who are very adherent, about 34% will use CPAP more than 4 hours every single night. And then this intermediate usage group who will do often a couple of nights of really good usage, and then they may skip a night, and then they may do a night of kind of less than 4 hours, but they keep going, and they over 2 years still using it consistently, but not always 4 hours a night. This is looking at the female treatment pathway, some data from Wickwire and the MedX Cloud, which is collaboration between industry and experts in the field that Resmed run. And what we're looking at here is that no matter which pathway people went down to get their sleep test done and then their treatment initiated, whether it's a home sleep test or a PSG or one of the other options, it took women consistently longer to get through the pathway than men. Not sure why or how this comes about, but yes, it's quite interesting to see that it's very consistent, again, with women just always taking that little bit longer to get through the pathway. But more alarming than that, this pie chart showing that after diagnosis, we'll see about 57% will end up on CPAP, about 2% will get some form of MRD, a small percent will go on surgery, but then 42% end up with no treatment. 42%, it's huge, and I think that's really a call to action for us. We need to do much better job at supporting these women after they've been diagnosed, getting them onto some form of treatment, or at least, getting them ready to think about treatment in the near future, because this is a huge drop off, and we need to do a bit of a better job looking after these women here. changing tact a little bit here and moving into cardiovascular again, you'll recall that I said earlier that women are more susceptible to cardiovascular issues. Women with OSA, that is, it seems to be more damaging. We've had trouble in our industry showing clear CPAP improvements in our randomized controlled trials. But when you look at the representation of women in total, it's less than 20% that have been included in all these trials, way lower than the proportion of males and females with sleep apnea. So I think another area we really need to do a much better job and take a closer look at when we're trying to understand the cardiovascular outcomes of obstructive sleep apnea. This was some nice data that just came out of Dr. Ko at the University of Tokyo last year, showing that women with OSA have absolutely a greater risk of developing cardiovascular diseases. Sleep apnea syndrome they used was associated with an increased risk of composite cardiovascular events, with a hazard ratio of 1.27 in men, and 1.72 in women compared to those without sleep apnea. And the association you can see significantly stronger in women than in men, and a huge data set that they've got in the Japanese claims database for 4 million patients. It's very compelling data. So moving on to my particular, one of my particular areas of frustration, which is daytime sleepiness, and our focus on using sleepiness as a screening tool, particularly where I live in Australia. In order for patients to get a reimbursed sleep test, they need to have an Epworth score of at least 8. And this becomes a real issue for two reasons. One is that when women go to their GP and talk about their issues, if they're not sleepy at that point, the GP is often given this wrong idea that, well, if they're not sleepy, I don't need to worry about sleep apnea. I don't even need to send them for a sleep study, and put that out of their mind. And then the second problem is that GPs who are a little more understanding of the system and trying to get reimbursement for their patients will put down levels of sleepiness that are high, and we end up with a bit of a skewed system of patients that are coming to our clinics, maybe not really representative of what sleep apnea looks like in the general population. So anyway, what we're looking at here is that a review of 15 studies, 42,000, almost 43,000 patients, found that global prevalence of excessive daytime sleepiness in OSA is actually only around 40%. So it's not even majority of our patients who have sleepiness, yet we've got this really hammered into our systems as kind of the number one symptom and the number one screener. The problem is we use Epworth so much, and Epworth, it measures how likely you are to fall asleep in different situations. And falling asleep is often not what women complain about. From the Sleep Heart Health study, we see that women can feel as sleepy as men, but they don't generally fall asleep unwanted in different situations. They're more likely to talk about things like feeling unrested, and in general, the Epworth is just not a good measure of sleepiness in women. This is some similar data, one that was published just last year, and out of the University of Miami, and some of our own data at Resmed. So from this data set, 53% of women not sleepy but have at least moderate OSA, and then 71% of women very sleepy but only had mild OSA. Sleepiness is just not, it's a really difficult one. It doesn't correlate very well with AHI, and it's not, again, the primary complaint that a lot of women with sleep apnea have. The data from, this is data from our own sleep clinic in London. everybody fills out the Epworth when they first come in, and we asked female patients to fill out the fatigue severity scale as well. And what we found was that 50% of women that came in, these are women with sleep apnea, that come into the clinic, they weren't sleepy, they didn't have high Epworth scores, but they had clinically significant fatigue scores. So yeah, again, I think we're just asking the wrong question about these women, about sleepiness in women. So just moving on to the very last section, new studies and what we're doing at Resmed. So this is a paper that was just published also late last year, trying to understand a little bit more why women with OSA have a higher risk of developing cognitive impairment compared to males with OSA and age-matched ales with OSA. So if we think about our hypoxia and fragmented sleep, what we know is that we've got these outcomes with inflammation, vascular dysfunction, impaired brain blood flow. It makes it much more difficult for the brain to clear proteins, beta amyloid, tau. But in particular, why do we see it so much in women? One theory that this paper comes up with is, well, maybe because women tend to have a lot more REM OSA, or their OSA is also often more severe during REM. Maybe it's this physiological stress during the time when the brain is at its most active, leading to more white matter injury and difficulty with the brain kind of doing its job. Yeah, quite a nice paper to read through if you wanted to try to understand or look at some of the mechanisms that this team are proposing may be responsible. This is just a quick one, looking at women with a history of gestational diabetes, finding that those who snored or snored regularly were much more risk for developing type 2 diabetes than people who never snored. They didn't measure OSA, but if we use snoring as a proxy, I think we see quite clearly in this group of women a risk of snoring and question mark OSA for type 2 diabetes development. This one I'm really fascinated by. They haven't published yet as far as I can see, so this data is from a press release at the moment, but this is from Withing, so 1.122 million women that they tracked during and post-menopause, and they can see from their data, from this kind of longer term data, significant transformations in sleep quality, in body composition, and cardiovascular health. It starts in perimenopause and then persists through postmenopause. And what they are saying is that women during or around this perimenopause time, waking up, or their wake-ups increase 33%. 33% increase in nighttime awakenings, 3 to 4 wake-ups per night, and sleep disorders, including insomnia and sleep apnea, increased by 374%. So huge. I mean, much bigger than we've seen from studies, but also 1.12 million is a very big data set. And also draw your attention to the very last dot point, the risk of cardiovascular diseases like AFib increasing 293% as women go through menopause. So huge. And I think we'll start to see, as we're seeing more wearable data and more of this data becoming available in the public space, we'll see more information like this really drawing a lot more awareness to menopause, perimenopause, and all of the health and sleep associations that come along with it that are more than just this kind of what in the past maybe people have felt like being brushed aside as that's just menopause, or it's normal to start sleeping poorly, or everything. Some of my patients tell me that the doctor being quite dismissive of everything's just menopause, to taking it a lot more seriously, and again looking after our our female patients a bit better. So to share a little bit about what we've been doing at Resmed, particularly thinking around this this sleepiness issue that I have been speaking about earlier, we've been looking to develop an OSA screener for women. We've gone through a few steps. The first was to look at the data that Resmed already have. So we actually have a sleep assessment. We have sleep tests that we can look at in our women that have gone through this pathway. What questions may be predictive of sleep apnea in women? Looking through all the literature in terms of reasons for referral, common symptoms, comorbidities that women at the time of diagnosis have. Trying to understand better particular terms or phrases or words that women with sleep apnea may use when they first start talking to their friends or family or doctor about how they're feeling, and trying to understand, you know, what may resonate best. And then, of course, expert consultation, we have global groups that meet regularly with experts in this space to try to understand from their point of view, speaking with and seeing these patients all the time, what we could do better and how we may be able to develop a screener that that picks up sleep apnea in women. So we've developed an app. The app is just in very early pilot testing at the moment. We're collecting a lot of information, and because it's an app, it makes it very dynamic and easy to swap questions in and out to kind of look at what may be predicting sleep apnea or what may be useless and move things around. So we've started doing data collection in Australia, US, and China. At the moment, we have over 700 participants. About 40% of them are female, around 48 years of age, predominantly whites at this stage, though we're working to get more ethnicities, and about 34% postmenopause. At the moment, our questionnaire looks like this. Again, this is very early days. We're still going to move things around and change them, but the items that we found important at the moment are menopausal status, symptoms in the morning, sleep problems, particularly linked to insomnia symptoms. Snoring, witnessed apneas are still very big predictors, of course. Morning symptoms, morning headaches, and common comorbidities. So far, what we found is that very consistently with all of the studies and all of the other literature, women absolutely have a greater symptom burden. They report poorer sleep quality, more insomnia, more pain-related sleep disturbances. Chronic pain has come up as a big one that we're investigating a little further because it may well be a strong predictor of OSA that doesn't come up so much in the literature. Fatigue and morning headaches. Comorbidities in this group, we definitely see anxiety, depression, chronic pain, as I've mentioned, thyroid issues being much more prevalent in our women with OSA, diabetes in our men. And in terms of OSA risk, the strongest one that we can see at the moment is natural postmenopausal women. And then just to highlight some of those results again, as I mentioned, we just see this high symptom burden in women, and we were looking at trying to find what would be the right term to use that women may, that may, you know, resonate better with women with sleep apnea. Is it low energy or tiredness, sleepiness or fatigued or unrested? And we had a few more in there as well. And women just rate, you know, they rate themselves higher in every single measure. And I also mentioned the trouble sleeping due to pain. So you can see over here that high percentage, about 70% of men are never having trouble sleeping due to pain, whereas women once a week, twice a week, more than 3 times a week. It's a reasonable proportion that are constantly disturbed by pain. So we're also at the moment trying to investigate a little bit more what types of pain in particular are the most common one causing injuries. We're going to keep collecting data. When we feel like this is strong enough, we'll move to validating it in a prospective clinical study. It's absolutely an open project where we'd love to hear from anybody who works with women with sleep apnea who's found something similar or found something different that we haven't thought of, or other questions that may be more valuable for screening for sleep apnea in women, and moving away from the reliance on sleepiness, or moving away from screeners that already give you a point for being male and are quite skewed towards males. And so this is bringing me to the end of the presentation today. Just to summarize, what we see is that women with OSA have different symptoms. They have milder sleep apnea. They're at higher risk of cognitive impairment, cardiovascular diseases, possibly diabetes, pregnancy outcomes as well. We haven't had time to go into that, but it's a whole other talk on the issues with pregnancy and sleep apnea, and the problems that women have and the babies have when the woman has untreated OSA during pregnancy. As I've spoken about, current scoring criteria and screening, it's too heavily reliant on sleepiness, and it really contributes to this idea of women being missed and misdiagnosed. And I think in the future, new pathways, screening, diagnostic measures, and treatment options may well be warranted to better look after our females with sleep apnea. This brings me to the end of the talk. I'd like to thank everybody for their time and attention, and particularly like to thank the SRS Foundation for the opportunity to share this presentation on sleep apnea in women. The recording of the webinar will be provided to all attendees and also placed on the SRS Foundation website. And thank you again. I'd be happy to hear from anybody who wants to ask questions or talk further, or as I mentioned, who's looking after a lot of women with sleep apnea and would like to be involved in developing a screening questionnaire that may work better for them. So once again, thank you very much. It's been my pleasure to be here today.